Welcome to this Ask the Expert session, where I will be answering questions regarding management of metastatic non-clear cell renal cell carcinoma. I'm Monty Pal, a professor and vice chair of academic affairs in the Department of Medical Oncology at the City of Hope Comprehensive Cancer Center in Duarte, California. If I were to see a patient with metastatic non-clear cell kidney cancer with metastases to the brain, I think that it's really essential that they consider getting a TKI-based regimen. There's several that I tend to use in the context of non-clear cell disease. The two regimens that are perhaps the most established at this point in time would be cabozantinib with nivolumab, or even cabozantinib monotherapy, and lenvatinib with pembrolizumab. Both are very reasonable options, I would say. The response rates for lenvatinib with pembrolizumab are particularly higher in the context of certain histologies like chromophobe disease. And my observation clinically has been that there's good brain penetration. We had a good paper in JAMA Oncology several years ago suggesting volumetric reductions in brain metastases with cabozantinib. And my clinical observation is that you can also see volumetric reductions in brain metastases with lenvatinib therapy as well. So I would suggest that a patient should receive a TKI-based regimen in the context of brain metastases in this setting. When I think about the decision between using cabozantinib with nivolumab or lenvatinib with pembrolizumab in the context of patients with non-clear cell kidney cancer, I think a lot about the histology. Now, for instance, if I look at papillary patients, which represents perhaps the most common non-clear cell histology, the data seems relatively balanced between cabozantinib, nivolumab, and lenvatinib, pembrolizumab. There might be slightly higher response rates associated with the latter, but I would say that you have to factor in questions of tolerability and so on. Where I really feel that lenvatinib with pembrolizumab might shine is in the context of patients with chromophobe renal cell carcinoma. That's a specific setting in which I think the data perhaps stands out with lenvatinib and pembrolizumab, and that's where I tend to use it most commonly. I think that it's going to be important to look at ongoing studies such as the cabo plus minus atezo study, SWOG 2200, and our other ongoing trials such as Stellar 304, which looks at zanzalintinib with nivolumab. I think that these are other promising TKI plus IO regimens that might potentially have a place in these diseases, but for the time being, I think the two that we've reviewed tend to be the most prominent. One of the things that I think is really important in considering patients with non-clear cell renal cell carcinoma is the evaluation of gene profiling. Now, this is not something that we do routinely for all patients with clear cell kidney cancer, although certainly it's something I think that could be attempted. And the reason I think this is so critical is that if we look at contemporary guidelines for pathologic classification, much of it really hinges on genomic abnormalities. So for instance, now in the current designations for non-clear cell kidney cancer, listed by the WHO and other groups, you'll see certain subcategories like ALK-mutated clear cell renal cell carcinoma or non-clear cell disease. And if you identify these driver mutations, they may really impact therapy. I remember several years ago, we actually had a series of patients that we published who had ALK alterations. And these patients who had kind of classic EML4 ALK fusions that you see in the context of lung cancer actually responded quite well to lung cancer-directed therapies like alectinib. So I think it's really critical moving forward that we consider gene profiling for most patients in this category. Two options that come up when a patient presents with brain metastases with non-clear cell renal cell carcinoma, and perhaps a variety of other tumor types, frankly, is whether to use stereotactic radiosurgery focused on specific metastases or whole brain radiation therapy. What we've really learned over the years is that whole brain radiation therapy comes with a number of different caveats. Patients can experience significant fatigue, discomfort, etc., many downstream consequences, frankly, from receiving whole brain treatments. On the other hand, stereotactic radiosurgery is far more focused, and I would propose that stereotactic radiosurgery is the option that I would favor for the vast majority of cases. In my experience, I think that you can treat multiple brain lesions. I've had patients with up to 42 lesions actually treated individually with SBRT and techniques like it. So if you can really push your radiation oncology colleagues to treat lesions individually, I think that's going to yield the greatest outcome with the least morbidity downstream. There's always been this question of what treatments may be optimal in terms of what to use with radiation therapy in the context of patients with non-clear cell metastatic RCC. I want to make one important distinction. If a patient is receiving radiotherapy to brain metastases, in that particular setting, I think it's really important that patients hold off on TKI-based therapy while they're receiving brain metastases. I tend to delay until after the radiation is done, and that's really to avert any risk of brain metastases bleeding out. On the other hand, for patients with metastatic disease at virtually all other sites, whether it's bone or soft tissue, I think that it's reasonable to actually continue your targeted therapy in the context of the radiation treatments. There's always certain caveats to this, but in general, I think that's a reasonable premise. We published some data years past at ASTRO meetings suggesting that it can be safe in a variety of contexts to use TKI therapy in the context of radiation. So I would propose that if you have a patient with non-clear cell metastatic RCC, you could stick with whatever regimen the patient's on, lenvatinib with pembrolizumab, cabozantinib with nivolumab, and treat right through it during the radiation. The main caveat, amongst others, being patients with brain metastases. Thank you so much for joining this Ask the Expert session. I hope you found this information helpful.